Wow, Dr. Bob, that was quite a sermon, I tell you. Remember those days back in speech class when we all had to come up with a speech to persuade? Yeah, he knocked it out of the park. A+. Okay. First of all, let me just go over a couple disclosures. I am going to make reference to the Joint Commission and a company that's known as WellBeing that provides a product we use. However, I am not employed by them, nor do I have any financial arrangements with them. Okay, I'm the St. Alexis Total Joint Program Coordinator. And a few years back, the physicians at Bone & Joint and the administration of St. Alexis decided they were going to pursue certification by the Joint Commission. This involved a lot of changes from our program that we had back at that time to be able to qualify for this distinction. Oops, wrong button. Okay. First of all, I want to clear up something here. People get mixed up a lot. Accreditation and certification. Accreditation is really something that is to the entire hospital, the whole organization, where certification is more specific to a program. So hospitals get accredited, but programs like cardiac, stroke, orthopedics get certified. Now there's a lot of different benefits of becoming certified that you can see outlined on this slide here. Having a standardized, systematic approach that the Joint Commission demands helps to reduce variabilities and outcomes, and it improves the quality of the care. But basically, it sends a message to the community that, that you're committed to a process that ensures that you are a center of excellence for the services that you provide. Around the time that this journey started for us, the mandatory CJR bundle kind of fell into our lap. I don't know if everyone is aware of that, but that has now come and gone. But unfortunately, the timing of this delayed our movement into the certification, as so much time was spent preparing for that. During that time frame in which we were a bit delayed, Joint Commission came out with their new advanced certification. There's a basic and then there's an advanced. The main differences is the basic looks at just the care that's provided during the time in the hospital, where the advanced certification looks at a longer continuum of care, starting from the first appointment in the orthopedic clinic through the hospitalization all the way up until the first post-operative clinic appointment. So really, when you look at the model of this, there's three parts to it. You've got clinical practice guidelines. There's over 150 performance, or excuse me, standards, and then there's performance measures, outcome measures. All of these combine, which should improve quality of care and improve safety for your patients. So, a little over a year ago, we were very excited to become the first facility in North Dakota to achieve this designation. Now, I know there's many of you here today that were a part of this, so I just want to take this opportunity to thank everybody for all their help and your dedicated efforts in this. Without you, we wouldn't have been able to make this happen. It was truly a team effort between the staff at the Bone & Joint Center and CHI St. Alexis. If it were not for Dr. Bob's passion towards joint replacement and his leadership, which helped to launch this program, much of this probably would have never happened. I also want to recognize Colleen Stalack, who's kind of my counterpoint at Bone & Joint. Her and I have been teaching the joint class for, gosh, I think it's 17, 18 years now. I also want to mention too, Shanna Williams and Mike Parr. They help us too with all of our guidance with patients and getting them through their recovery. So when you look back a little over a year ago, there were 28 programs in 15 states that had achieved the advanced certification. About a month after that, we became the 31st facility in the United States and the only one in North Dakota. A couple weeks ago, there were over 60 programs in the United States now. 2 were in Minnesota, none in South Dakota or Montana, and just us in North Dakota. So one of the first things we had to do is we had to put together a interdisciplinary team. We broke this apart as to a core team and an ad hoc team. Core team, we had to have a representative from each of these areas meet monthly, and what we would do in these meetings is we would review the status of all of our performance measures. We will go through and review complications, emergency room visits, readmissions if there are any. We try to learn from this so we can help change things to provide better outcomes in the future. We also look at any new clinical practice guidelines that may be out there that we should be looking at, and then we go and establish goals for every year going forward. So when you look at performance measures, these are things that are designed to measure the quality of your program. All of these measures that you create get analyzed, and we report them back to the Joint Commission. Here what you can see are in red are the new mandatory performance measures that the Joint Commission came out with. Discharge to home, they see that patients should be trying to return home directly from the hospital following a knee or hip replacement. They feel that patients should get some form of regional anesthesia for a knee and hip replacement. Patient-reported outcomes, what that is it's a pre-op and a post-op functional survey of their joints' functions. So a patient will fill out a form prior to surgery telling them how their knee or hip arthritis is affecting their life, and it actually comes out into a raw score. We then test them 9 months after surgery, asking them the same questions. This data will be very helpful going forward when we look at value-based care and everything, is that it really shows that what we're doing is improving not only the function of their joint, but the quality of their life. And then day of surgery mobilization, getting people up early after surgery is a big part. The remaining ones were ones that we created. They were more voluntary that we look at, whether they've gone to a pre-op class, discharged home, hopefully the day after surgery or sooner. Patient satisfaction was a big one. And I'll talk more about that in a little bit. Blood utilization, gosh, we should almost retire this one. I don't know when the last time was we had to give a transfusion. Complication rate, this is something that we have a system that if there's a code that is rendered during their hospitalization, like urinary retention or a respiratory problem, that gets put onto our report. We look at anybody who's gone to the emergency room or been readmitted into the hospital. And just to kind of support Dr. Bob's last talk, one of the more common emergency room visits over this last year have been linked to those opioids. And so we mention that a lot in our class now, and we're starting to emphasize that more. Of course, length of stay, return to the operating room. Our guided care path, known as WellBeing, we look at how well people are using that, and then of course infection and blood clot prevention. So these things are all looked at every month, and basically it's kind of our report card, if you will. If you look at how school is, and we look at this is kind of hard to see, but it's just a sample of one of our monthly reports that we'll look at and make sure that we're achieving our goal and staying in the green. So, what did certification really do for us and our patients? So let's take a look at some before and after data. Okay, so before in 2014, we didn't have standardized orders or a real formal risk assessment for surgery. Criteria to have surgery was really not very well defined and really quite variable. Now, we have orders and risk assessments that are standardized in accordance with evidence-based research. And because of this, it's helped us to reduce post-operative complications and promote more consistent and better outcomes. Before certification, well, we always had a class. We've had a class for a long time. We didn't make it mandatory, and we kind of just covered the basics or the high points. Now, class is mandatory, and it's much more comprehensive than it used to be. We also have coaches, which we tell that the patients need to have, and both the patient and the coach attend class. Okay, patient education back then consisted of a lot of white papers all shoved together and given to the patient during the hospitalization. This was a very disorganized mess at times, and patients really struggled to find the information that they needed after they got home. So, one of the first things we did is we made what we felt was a good comprehensive book. Patients get this spiral-bound book, and within it we put in all the information to all the common questions that they had and mistakes that patients had made in the past. So we have troubleshooting, phone numbers to call, frequently asked questions. We then use a web-based guided care path that we send out to patients. This operates through their email, and it's a really good resource for them because it has a bunch of educational videos on there, so if they go home and have forgotten how to do something or can't remember how to do that exercise or how to work their ice machine or something, we have videos in there that they can watch. Plus, it also provides them with feedback on their recovery. It lets them see what should be kind of an average patient functioning at 2 weeks after surgery. So this has really helped them to kind of gauge their progress. It's also something that we use to help measure our patient satisfaction, as it asks them the specific questions that we really want to know about their experience with us. So, before certification, we didn't really have a structured system that checked in with people to make sure they were doing well after they went home. We hoped they knew what they were supposed to do, and oftentimes they got kind of mixed up and didn't really understand. Now we have a much more structured system in place. All patients are called the day after they go home. We also do a follow-up call about 1 week out from surgery. Our guided care path sends them emails on day 3 and day 10, so we're definitely staying more connected to these patients and helping them out with the technology we have available to us today. So, back then, boy, length of stay for a total knee in the end of 2014 was about 3.1 days, and for hips was 2.5. And I think this is as of February, we were down to 0.7 for both knees and hips. So, I did hear a rumor that Dr. Bach was putting in a drive-up window for filling meals at one of his restaurants. I think he's going to talk about that next. We'll hear about it. I don't know. But when it comes to length of stay, the one thing I've always said is it really is meaningless if your patients aren't satisfied and feeling well prepared to go home. So it was hard for us to measure patient satisfaction back then. Those of you who are familiar with the HCAP surveys that hospitals send out, the response rate on that, I believe, is 20% or something, not really great. And it was very hard for us to single out our elective joint replacements because they would get sent out to hip fractures and patients like that. So it was really hard for us to get a handle on patient satisfaction. So with our guided care path, we're actually able to ask them questions like, was your pain tolerable? Would you come back to us again? Did you feel prepared to go home? Was the staff, was the care good, and things like that. Those are the basic questions that make our patient satisfaction. And this is something I think we're all very proud of, that we've been kind of able to stay in that 95 to 98 percentile. A lot of the feedback we get from patients has gone into our preoperative teaching, and I think the hallmark of patient satisfaction starts with education and establishing their expectations and setting them accordingly. If people are expecting this, but you give them that, they're not going to be happy. So, anyhow, thank you.